everybody, and welcome to the August edition of the European Urology Podcast. My name is Declan Murphy, urologist here at Peter MacCallum Cancer Centre in Melbourne. I hope you're all having a wonderful summer if you're in the Northern Hemisphere, or you're struggling through the winter like I am down here in the Southern Hemisphere. I'm joined as ever by my co-host, Dr Nikita Bhatt, Urology Fellow at Newcastle in the UK. Nikita, how are you up there?
I'm really well, really enjoying the weather while it lasts our 2 months of summer and your 2 months of winter. So it's only fair. But no, really enjoying the weather and the last couple of months of my fellowship.
Yes, so exciting news. You're finishing your training and you're moving to your new consultant job over in Dublin, in my home country, Ireland, I believe.
Absolutely. Yeah, very excited to go back to where I came from. So I did my basic surgical training there. So excited to go back and start my new job. So, it's a mix of positive and negative because you're afraid and terrified, but at the same time, excited to start the job. So
let's see. It's great. We're very happy for you. You're joining a great team at St. Vincent's in Dublin. And your husband is also working in Dublin, so it's very exciting for you and him and the kids, and we wish you all the very best. And you're going to stay on the European Urology Podcast, I'm pleased to say, which is great.
Absolutely. Thank you.
So look, we've got a cracking podcast coming up. Now, for those of you watching on YouTube, you might have noticed I'm wearing this ridiculous red rugby jersey, and we will explain all that later in the podcast when Eoin Dinneen joins us for the wrap-up section of the podcast later on. And yes, it's not the normal attire. And Nikita was asking me what the heck is going on, but all will be explained if you want to hold on until later in the podcast. We have highlighted two of the fantastic papers that are in the European Urology Journal this month, one of which is on MRI and active surveillance, led by the team at UCL, Carolione Moore and co. And the second is the Surgery in Motion paper this month, from Professor Zhang and team at Zhengzhou in China, who have presented this incredible description of technique of robotic nephrectomy for level 3 caval thrombus, a single docking technique. So that's coming up later. But first, Nikita, let's go to your interview with Professor Carolione Moore in London.
Hello, Professor Moore is joining us today. So we're very grateful that she has agreed to interview with us today for her paper on MRI in active surveillance. Although Professor Moore needs no introduction, I'm going to ask her to introduce herself and to tell us a little bit more about her wonderful paper.
Thank you. So I'm Professor of Urology and Head of Urology at University College London. I work entirely in prostate cancer, but I don't take out prostate. So I do all the other bits that urologists do, from screening through to detection, surveillance and focal treatment, with a big focus on MRI. And the paper is really the collated cohort from our clinical work at UCLH over the last 20 years or so. We last published it over 5 years ago, and we've now got a much bigger cohort with longer follow-up in our MRI-led active surveillance strategy, which is our clinical approach at UCLH.
Excellent. So for our readers, you've provided a brief summary, and I just have a few questions to follow up on that. In terms of, you said you use MRI for active surveillance, and you've been using this for a good few years, and obviously everybody is aware that UCLH is one of findings in other centers that may not have such experienced uroradiologists, do you think?
Yeah, so I think there's sort of two elements to it, really. And I think it's fair to say that a lot of people are using MRI, particularly before biopsy, and it's really just continuing that journey. So what I might say, in the olden days, which we know are still carrying on in some places, some people might still be using a standard biopsy either instead of or as well as an MRI, irrespective of the MRI results. And that's a common practice in active surveillance, where irrespective of, for example, low risk cancer on the first biopsy and a negative MRI, some people will be doing a repeat biopsy because it's the time of year for a biopsy, because Repeat biopsies was a kind of an approach when there wasn't MRI. And so I think just as the use of MRI before biopsy and MRI to avoid biopsies growing, I think MRI as the primary tool in active surveillance with biopsy as needed could certainly be more widely adopted. We are looking at a specific study of that where we risk stratified patients. So that study is called Measured MRI-Enabled Active Surveillance, using risk-adapted decisions. And that's really saying that those people most likely to progress, and the paper that we've published shows that that's the men with MRI visible Gleason 3+4, are more likely to progress by a long way and should therefore have different monitoring to those people with non-MRI visible Gleason 3+3. And I think those approaches can absolutely be adopted by anybody who's using MRI in the primary setting.
Okay, thank you. Can I ask you to tell us the headline figures? We want our readers to go back and read this paper in our journal. That's the whole point of doing this podcast, but it'll be nice to have some headline figures of your findings, because you've just mentioned about the MRI visible 3+4, and I was very interested to see how much of the event-free rate was different compared to the non-visible lesions. So if you can give us a little bit of a flavor, if you may, of your findings, that'd be great.
Yeah, absolutely. So the cohort was 1,150 patients with a median follow-up of 64 months. And at baseline, about a third of men had Gleason 3+4 disease, 2/3 had Gleason 3+3, and about half of men had an MRI visible lesion. And we see MRI visibility as one of the primary risk factors along with Gleason score. So we then looked at subdividing the cohort into those with non-visible 3+4, where we had an event-free survival at 5 years of 91%. So it just turns out that MRI visible Gleason 3+3 and non-visible Gleason 3+4 have similar event-free survival, so about 70% at the 5-year time point. And then for those men with MRI visible Gleason 3+4, 44% event-free survival, so more likely than not to have treatment by 5 years. But even so, 44%, that's certainly well worth starting on surveillance if that's their preference. And my approach would be to say that preservation of function, if that's what the patient places a priority on, is worth it even when we know it's unlikely to be the only long-term strategy. So I think there's real value in deferring treatment for some patients rather than only wanting to use surveillance to avoid treatment.
Great.
And the other sort of headline figure is that only about less than half of the patients had a follow-up biopsy. So when we only do biopsies as needed, we really reduce that follow-on biopsy rate.
Okay. So it's really interesting about the 3+4 Gleason cancers undergoing active surveillance. And in your paper, you've mentioned that towards the latter half of the study, that proportion increased and actually became the more predominant cohort, which I think may not be the practice in a lot of centers or currently, as far as I'm aware. I haven't been doing prostate cancer very closely, but as a trainee is what I've seen. What would you say to everybody who is not doing that from your experience in terms of managing these 3+4 patients, predominantly, it seems, on active surveillance?
Yeah, so it's not that we predominantly manage 3+4 on surveillance, because some men diagnosed with 3+4 at UCLH will go straight onto treatment, and it depends on the tumour volume and the patient preferences and other factors. But what we have really reduced is the diagnosis of non-MR visible Gleason 3+3. And that's because for a man with a negative MRI and a low PSA density, we don't do a biopsy. So therefore, that cohort is really reduced over time. And so the commonest people that we biopsy are people with an MRI lesion. And some of those, the smaller volume ones will go on to active surveillance, knowing that they might need treatment in the future, but that they don't have to have it yet.
And in terms of going to the non-visible lesions on MRI, your sort of follow-up pathway for that is quite pragmatic. It's quite clinician dependent on PSA kinetics. And I assume that would introduce a bit of variation in how people manage these. Is there a set criteria that you follow locally? And how do you think this can be sort of, again, generalized in other centers? Is there some sort of advice that you would have for managing and following up these sort of patients?
Yeah. So I think, I think for centres who are not yet doing this and are interested, they might want to look at taking part in our new prospective study, where the plan for many of those with non-visible disease at the lower end of risk will be an MRI at 1 and 5 years, and of the more intermediate risk will be at 1, 3 and 5 years. But clinically, what we've done is that we don't do routine biopsies, so they don't get a biopsy sort of because it's the time of year for a biopsy or anything like that. They'll get a biopsy, a follow-up biopsy, if a new lesion appears. And we do see, particularly with the non-visible Gleason 3+4s, that a lesion does often appear over time. Or if the PSA is rising and we can't explain it, because we know that not every cancer is visible on MRI.
Okay. So you've kind of answered my next question already. For the MRI visible disease, then in your study, they had a baseline MRI then at 12 months and at 24 months. So, yeah. But this is quite a long-term follow-up study. So would you recommend more stringent MRI follow-up going forward? Say if someone wanted to set this up in their center, you've just mentioned that you've got a study recruiting. Is this also for MRI visible lesions, or is there any advice in that area?
Yeah, MRI visible lesions will be included in that. And I think it's interesting. What we tend to see is that we know that prostate cancer risk and risk of prostate cancer death goes up as men get older. But we also see that men get kind of fatigued or bored of surveillance. And so what we see in the big biopsy cohort studies is that actually biopsy compliance falls over time, which by its very nature is when risk is rising. So, and in active surveillance, we're always trying to balance the risk of what's the risk of the prostate cancer, what's the risk of treatment, and what's the risk of other medical conditions. So we don't have a set protocol because it does depend on those variables. So in the study, there'll be a protocol where MRI visible Gleason 3+4, most of those men will get an MRI on an annual basis, and we expect that by 5 years, half of them at least will have gone on to treatment. But I think in terms of the other factors, it's really important to weigh up those other factors, including the question of what will we do if there is change? So for a man in his late 70s with bilateral visible disease who doesn't want to have it now because he needs to look after his wife with a hip replacement or something like that, it may be that we say, okay, if there's growth of either lesion or if the PSA starts going up at a higher rate, then we'll step in. It'll be radiotherapy rather than something else. Whereas for a younger man with a small lesion, he's still got all options open to him if things change.
Excellent. So very exciting to have, MRI entering, and I'm sure lots of centers are already using it now for active surveillance. Can you elaborate briefly your study that are you recruiting to that? Because my next question was, what's the next sort of big area of research in this field? But seems like you're on it. So if you can tell us a little bit more about that study, please.
Yeah, so it's in setup at present, going through the last stages of funding mechanisms. It's in collaboration with Movember and Prostate Cancer UK. We're looking to recruit about 750 men internationally and across the whole spectrum of men being enrolled on active surveillance. So Gleason 3+3 and Gleason 3+4 with MRI non-visible or visible disease. And we'll be looking at the frequency of tests. So we have a risk stratification table, and we'll be publishing that in the next year or so, looking to predict the likelihood of progression for any man. And then once you've got that likelihood, you stratify people's follow-up by their likelihood of progression. So men most likely to progress get more tests than men least likely to progress, who can safely forgo frequent MRI scans and certainly biopsies. So that's still in setup phase. Got a little while to go yet, but we hope we'll start recruiting for that sometime next year.
Excellent, very exciting. Excellent work again coming from UCLH. Thank you so much for joining us. Really appreciate you giving us your time. And to our listeners, hope you go and read the paper. It's very interesting, even though I don't, like I said, closely manage prostate cancer anymore, but I found it very interesting. So I'm sure you will too. So thank you so much, Professor.
Great, a pleasure to be with you. Thanks for the invitation.
Did you know, Nikita, that Carolione Moore was our first ever guest on GUcast, the parent podcast for the European Urology Podcast back in 2020? So she is my most favoured podcast friend on GUcast. So yeah, that was a great interview.
Yeah, I mean, she is phenomenal, so impressive, such an inspiring female academic surgeon. And, you know, the work that they've done in the field of MRI and prostate cancer is absolutely, you know, phenomenal and has changed practice, as we're all aware. And they continue to do that. So very, very impressive.
Yeah, and I think this one of what is the role of MRI in active surveillance is very, very important for the countries that have been able to embrace MRI for early detection. Then it rolls into active surveillance. How often can we be doing it? Do we need to be doing biopsies? And that's the key attraction, of course, is can we avoid biopsies? And this is a very informative paper for those of us doing a lot of active surveillance. So yeah, wonderful. Congratulations and very nice interview. So yeah, now let me go to China to Professor Zhang and team at Zhengzhou University to talk about the other paper we've highlighted this month, which is robotic radical nephrectomy for level 3 caval thrombus. Very complex surgery and a very nice description of their technique. Now, unfortunately, Dr. Zhang couldn't join us live for the recording of this podcast, but we've still, of course, decided to go ahead and highlight this very interesting paper in the August edition of European Urology. It's in our Surgery in Motion section, and it's titled Robotic-Assisted Single Docking Approach for Level 3 IVC Tumor Thrombectomy. So why have we chosen to accept this paper and highlight it in the journal? Well, I think it does represent the very far end of what can be achieved with minimally invasive robotic locally advanced kidney cancer surgery. And while this type of approach for level 3 thrombus has been described before from expert groups around the world, what's a little bit novel about this one is the fact it's a single docking of the robot to do both the nephrectomy and the IVC tumor thrombectomy, rather than what's usually described as a dual docking or double docking approach. Now, because this is in our Surgery in Motion section, there is, of course, a very nice surgical video going with this, which describes some of the operative approaches and some tips and tricks. So I encourage you to go and look that up yourself. I am showing a few little highlights here over the next few moments. What they also do in the introduction to the video is describe one of the 15 patients in this study, a 59-year-old gentleman with a right-sided renal tumor thrombus extending to the infradiaphragmatic IVC, meaning this is a level 3 thrombus. You can check out more of the surgical details in the Surgery in Motion video yourselves. So what's our take on this paper? Unfortunately, Dr. Zhang can't be with us to discuss in person, but I think it's fair to say we acknowledge that this is the type of minimally invasive surgery that can really only be done in the hands of teams who are very experienced in doing surgery for locally advanced renal cancer with an open surgical approach, and also have the requisite skills to tackle this using a robotic-assisted approach. And that certainly seems to be what Dr. Zhang and his team have shown us in this paper. So should this be some sort of new standard of care for level 3 tumor thrombectomy, locally advanced kidney cancer? Well, I think most of us will accept that this is complex surgery, this is high stakes surgery, and I think it's fair to say that whichever surgical approach the expert team is most comfortable with is the best approach for the individual patient. And I think what that means for the vast majority of centres around the world is that this will still be an open surgical approach. Nothing wrong with that. While it is tempting, of course, to try and get the minimally invasive benefits compared to the rather large open surgical penalty of doing this type of surgery, still, I think patients faced with this type of advanced oncological situation will accept the morbidity of open surgery, provided it gives them the best chance of a good result. So what were the results like in this study? Well, operative times were about 225 minutes. Recorded intraoperative blood loss was about 400 mils, but they do acknowledge that about 80% of patients had an intraoperative transfusion. And the median IVC occlusion time was 14 minutes. 20% of patients had a level 3B Clavian Dindo complication or higher. And at 2-year follow-up, 5 patients, 1/3 of patients had passed away. So in summary, congratulations again to Dr. Zhang and his team for this very nice series, this very nice description of an advanced surgical technique. It's great to see this, but I caution that this really can only be done by teams who've got both the experience of managing a lot of locally advanced renal cancer up to level 3 by whichever surgical approach, which is typically open. And they also have to have the requisite robotic-assisted skills to take on this type of surgery. So it's probably not for everybody.
Wow, that was really interesting, Declan. And the robotic surgical limits are really being pushed everywhere in the world. So it's very, very exciting. That video was really good as well.
Yeah, Professor Zhang and his team have done a beautiful job on this. And it just shows, the boundaries can be pushed with what you can do with the robot. And I think nephrectomy for a level 3 caval thrombus has always been something in the purvey of open surgery. Better not try that with the robot. But yeah, it's wonderful to see the envelope being pushed and extraordinary extreme surgery really. So yeah, congratulations to Professor Zhang and team. The links are in the show notes and the video is on the surgery in motion section. So yeah, fantastic. But Nikita, for our final segment, as ever, I've been joined in the studio here in Melbourne by Eoin Dinneen, my fellow here at Peter Mac, who normally covers this segment that you used to cover, which is where we wrap up 3 other things that have caught Eoin's eye in European Urology this month. Eoin, welcome into the studio again to the European Urology Podcast.
Thanks, as ever.
Now, as I said at the start, Nikita, I do look ridiculous in this bright red jersey for anyone watching on.
Nice.
You think it looks nice? Yeah.
Dahlia.
And I said we would explain what this is all about at the end of the show. So, Eoin, before you dive into your top 3 other bits in European Urology this month, can you please explain these jerseys for anyone watching on YouTube?
So we're on the eve of test 2 of the Irish and British Lions against the Wallabies here in Melbourne. And so Melbourne is gripped by lions, tourists and expats representing and cheering on the lads against the Australian national team.
And understanding that the vast majority of our audience have no idea what the Lions are. Can you even mention what sport is it you're talking about?
Rugby union.
Rugby
union.
Thank you, because I didn't know.
Thank you, said Nikita. Exactly. Yeah. So it's a big event, isn't it? So just to explain briefly, it's a composite team made up of the best rugby players from listed out. Yeah.
England, Ireland, Scotland, Wales.
England, Ireland, Scotland, Wales. So the best rugby players once every 4 years take off on a bus and head down to the Southern Hemisphere, and they either go to New Zealand or Australia or South Africa. Once every 4 years, they go to one of those countries and they play a series of test matches and
comes around every 12 years.
Every 12 years,
one of those
exactly.
Countries.
So it's very. It feels very special here. The Australians certainly are very, very enthusiastic about this opportunity, which only comes every 12 years. But lots of tourists come. All these great rugby supporters from those 4 countries set off down here to the Southern Hemisphere, and us locals who live here, who love our rugby, put on the shirts, and we've been out enjoying
and cycle to the matches.
Yeah, we did one
after a day at work. Yeah.
Oh gosh. Melbourne looks like a sea of red.
I know. So there you go. That's the explanation for why we're wearing British and Irish Lions rugby shirts here in the studio. But I suppose we should crack on before we lose the entire audience. Give us your other top 3 highlights from European Urology this month, August.
Thank you. My pleasure. So 3 things as ever this week. So firstly, I've got an editorial, then I've got a cutting edge communication, and lastly, a review. So I'll start by an editorial written by Bhaskar Samani and Evangelos Liatsikos, excuse me to him if I've pronounced that incorrectly. Professor Samani from the University of Southampton in the UK. Unmet needs in urological education, the role of the European School of Urology in addressing and advancing global knowledge. This is a really short read, less than 2 pages, and essentially it describes the consumption of content from the European School of Urology. They look at, where in the world, what is being consumed, and suggest that the ESU could be a vehicle for advancing global understanding of urology. And I think that's a really noble and lofty ambition. Couple of small tidbits for you. Did you know there were 137 podcasts released last year by the ESU, and there were 146,500 downloads of that content? And that's just their podcasts. That doesn't include e-courses or live streams. And of course, it doesn't include the EU cast actually as well, which might bump that up significantly, as well as, of course, the conference rosters and stuff like that. So I would just point out that they notice, and they point out in their article, that only 10% of this is downloaded by lower and lower middle income countries. They say that this is still going on in a big way, but they identify this as a vehicle for perhaps improving urology education and the quality of urology care provision in these countries. So my comment on this one is that these are certainly lofty ambitions on behalf of the ESU, and I commend them for making this and identifying this as an ambition for the future. And quite secondly, it's a reminder of the wealth of online teaching available from the ESU. And the first thing I did after reading this article was went onto YouTube and subscribed to the ESU in the hope of learning something that might benefit my future practice.
Free resource. Wonderful.
Absolute 100% free.
We should put a link in the show notes.
Like the EU cast.
Yeah, exactly.
Like the GU cast.
Excellent. Love it.
Right. Second one. This is super exciting, cutting edge innovation, change happening in front of our eyes. So this is cutting edge communication, consolidative surgery for advanced urothelial carcinoma following induction with enfortumab vedotin and or immune checkpoint inhibitor therapy, a multi-center analysis. First author is Daniel S. Robertson. Last author is Abhinav Khanna. This is a group from the Mayo Clinic across 3 different sites in Rochester, Minnesota, Scottsdale, Arizona, and Jacksonville, Florida. It's very, very short paper. I'm sure this will be followed by longer communications and presentations on the international scene. But if you'll allow me to go back before I go forward, last year, bladder cancer specialists will be well aware that EV302 Keynote A39 read out at ASCO, written and presented by Tom Powles et al. Of Barts in London, with a co-publication in the New England Journal in June 2024. And it compared enfortumab vedotin plus pembrolizumab against standard of care, gemcitabine cisplatin, in advanced or metastatic, i.e. nodal or T4 disease, urothelial bladder cancer or kidney cancer. And they noticed an improvement in overall survival median of 16.1 months in the standard of care to 31.5 months in the intervention arm, i.e. EV and pembrolizumab. In the context of such favorable responses, many patients with advanced urothelial cancer may be rendered eligible for consolidative local therapy. And this is an initial multi-center retrospective cohort study of such patients. It's small, but all of these patients are bad actors, T3, N1 or above, or M1A, 60% of whom have never had any prior therapy in the way of cisplatin. And although the median length of follow-up is very short at 10 months, these patients are doing really well. There is a significant caveat to their results in pointing out that 3 patients died during the follow-up time, and 2 of those, the cystectomy or the nephroureterectomy was done with palliative intent. But amongst the 26 patients who underwent consolidative surgery after EV plus minus pembrolizumab with curative intent, only 3 have had recurrence to date. 22 patients, or 79%, have had complete cessation of systemic therapy subsequent to their cystectomy or nephroureterectomy. And in addition to that, the last thing I'll say is downstaging in 23 patients, 12 of whom experienced complete pathologic response. The doors are going to open for this type of consolidative surgery in advanced, i.e. metastatic or nodal positive at the point of diagnosis urothelial cancer. This is exciting. It's going to be super interesting to follow these patients, to follow what else comes and other centers that are doing it. And my comment on this is that previously in these patients, discussion through the MDT has been in one direction. It's been from urologists to oncologists. I think we're going to see patients coming back towards surgery from the previously patients who would never have returned to urologists.
And it's a very nice,
very exciting.
Yeah, it is interesting, Nikita, isn't it? And, later this year, we are going to see the very big phase 3 randomized trial of EV Pembro in the neoadjuvant setting, randomized up against neoadjuvant chemo in cis-eligible patients. And, the rumor is that'll be out at ESMO this year, and that's a phase 3 randomized trial registration trial. So if it's as exciting as it was in the metastatic setting and in this little teaser, it'll shake things up big time. So.
So get a glimpse of it here in this month's edition of the European Urology, I do believe. My last piece for you is a review. It's slightly unusual in that it's primarily written by a management consultancy group from the UK who've been commissioned to do this large systematic review of sorts. This is prevalence, socioeconomic and environmental costs of urinary incontinence in the European Union. First author is Chrissy Bishop. She's with some colleagues from a health policy and economics consultancy called Triangulate in the UK, with 2 members of the EAU there as well. This is a review article. It's quite long. It's 6 pages. It's quite dry in places. Commissioned to inform the Urge to Act campaign, a policy initiative led by the EAU. I'll just give you a couple of headlines that I found a little bit interesting. Guess what? Incontinence pads, how many are sold in the EU every year?
Gosh, very large amounts, Nikita, I suppose.
Millions.
Try billions. Wow. 39 billion units sold, globally in 2021. Very few studies inform our understanding of this non-life-threatening but serious health and economic, disease on the impact of individuals' financial health and that of countries. This is a review of the published literature, and also questionnaires were sent to 27 national urological associations. I did laugh a little bit at the thought that only 13 national urological associations responded to an invitation to questionnaire, which makes me think about the response rates even when questionnaires are sent out from national urological associations. So I would just summarize by saying overall it shows the staggering cost of urinary incontinence to the individual and to nations. We're talking in the region of 0.5 to 0.75% of GDP in the countries that were included. And I suppose the endeavor here, the point of it was to quantify the cost of this before preparing recommendations and measurements to improve the situation. And I would commend the authors as well for including environmental impact, including recommendations for the recycling of this absolute mountain of incontinence pads that the European Union is going through every year, as opposed to incinerating them, which means that we all end up breathing them in the subsequent months and years. So good work. That's it.
Nikita, what do you think?
Oh, I mean, I deal with incontinence and I know how debilitating it can be and financially completely causing a wreck, especially a lot of these people are retired and having to buy, large pads, and it's just really, really expensive. And I really do wonder about the environmental impact. So it's really hard to measure that. But these authors, I've read this paper and I've done that. And as you would expect, it's a lot. So I'm sure hopefully in the future, we'll find better ways of managing incontinence that don't affect us financially to this level and to the environment.
Yeah, for sure. And it is interesting, isn't it, to see a paper like this in a journal like European Urology. I think it reflects that the EAU, from a policy level, are taking an interest. So this is not your classic research paper written by academic clinical people. It's coming from management consultants who've been commissioned to do this type of work, but that's informative. And the fact it's been given a slot in the big journal, I suppose, tells us it's going to be important for our society.
And for good reason.
Absolutely.
Because they estimate the per patient per year cost of urinary incontinence across the EU countries is €1,470.
Wow.
It's not
a lot of money.
Big deal.
Great. So things we can do, I suppose we're aware of it, things we can do to reduce it or better manage it, and most importantly, improve quality of life for patients living with incontinence is going to be the key. So Eoin, great job. Well done. Thank you. Nikita, that's all for us on this month's edition of the European Urology Podcast.
Yeah. So thank you everybody for joining us. Please like, share, subscribe to this podcast. And if you have any feedback for us, to let us know, rate and review us, and we'll see you next month. Thank you so much.
Will do. Take care.
Thank you.